اوكي نبدأ. اوكي. بسم الله الرحمن الرحيم، الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Dear colleagues, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here in this scientific event where we are privileged, in fact, to have two eminent speakers representing international and local expertise in the field of type 2 diabetes management. And before I start, I would like to thank the organizing committee, and I would like to thank the Saudi Society for Family and Community Medicine, who are having these scientific event under their umbrella. And I would like also to thank Novo Nordics for bringing us, all of us together in this platform to exchange knowledge and to share experience in a very important topic, which is the CKM. So before I start, ladies and gentlemen, I would like to introduce myself. I'm Dr. Ashraf Amir. I'm a consultant family medicine in the International Medical Center. I'm the Vice President of the Saudi Society for Family and Community Medicine, and I have been privileged here today to moderate this session. So regarding my disclosure, there is nothing to disclose. And before I start, I would like to pave the way and set up the stage by saying that in the management of diabetes, we have been managing diabetes for many decades through our practice. And in spite of the revolution that happened in the management of diabetes, we have a very updated guidelines. We understood the pathophysiology of diabetes, and we have smart molecules. Still, we are in a position to say that we did not control diabetes effectively. Why? Because there is a lot of confounders. In fact, there's something related to patient, something related to us as a physician in terms of clinical inertia, and something related to the healthcare system. But if we just look into diabetes as a major health problems across the globe, where more than 557 million adults are live with diabetes, but diabetes is not only a disease, but it's also a disease that is progressive to the extent that it might land in certain complications. And it's very surprising and astonishing, and it's very important for us to understand the complication of diabetes and the consequences of uncontrolled diabetes. So we know that there is more than 4 million people across the globe, they remain untreated. So it's almost 60% of our total population. So this is a huge number of populations, and definitely they are promoted to demonstrate the uncontrolled diabetes with its consequences in terms of morbidity and mortality. Unfortunately, there is suboptimal adherence to the treatment. So only 50% of our populations of diabetes, they are adherent to the medications. And as we know, about 50% of our populations, they could achieve, or they achieved the target A1C of less than 7, but according to our local studies, it did not reach the 50%. It might be around 30 to 35 or 37% of our total populations of diabetes in the Kingdom of Saudi Arabia. They achieved the target goal of 7%. 80% of our people with type 2 diabetes, they are overweight and they live with obesity. And of course, this will shed the light on a very important syndrome that we have to look into. And now we are in the era of not treating diabetes as a single clinical entity, but it's usually associated with a multiple comorbidities and multiple medical conditions. So nowadays we speak a different language of medicine when we talk about diabetes and other associated comorbidities in terms of cardiovascular, kidney, and metabolic disease, which is the CKM. So this represent that many of contributing factors for this syndrome, like obesity, where we have millions and millions of people, they are obese, type 2 diabetes, cardiovascular disease, and chronic kidney disease as well. And we have also the metabolic dysfunction associated liver disease, which is the MASLD. This is the new name for the previously NAFLD, which is non-alcoholic fatty liver disease. And this represents the fat accumulation in the liver, which is hepatic steatosis. So this is the complicity of the cardiovascular, kidney, and metabolic, and these diseases are rarely occur in isolation. So now we have to change our mindset and think broadly about the interconnections between these clinical entities to formulate this kind of syndrome. So unfortunately, those people with type 2 diabetes across our spectrum of practice, we know that these people are more prone to have cardiovascular disease. And we know that 30% of patients with diabetes, they are at risk of cardiovascular event. And the event of the cardiovascular mortality and morbidity is almost 2 to 4 times, 2 to 4 folds more in type 2 diabetes when they are compared with non-type 2 diabetes. People with chronic kidney disease on the other spectrum, because we know chronic kidney disease is one of the complications of diabetes, and it was one of the very important cause for end-stage renal disease here and kidney transplant in the Kingdom of Saudi Arabia. So those people, they die from cardiovascular at early stage, and it depends on the stage of the progression of the chronic kidney disease all the way till they reach the end-stage kidney disease. Cardiovascular disease is a leading cause for mortality in type 2 diabetes. Approximately about 50% of those people are subjected to premature death. So, of course, when we talk about the worsening glycemic control, it is always associated with the uncontrolled A1C. So, as you can see in the graph on the left side, so the more A1C, which is not attained to the normal, to the target goal, the more is the increase of the cardiovascular mortality and death. So it reached almost 100 times in terms of patients with A1C more than 9.7%. But this is not the story. The story is also to say that the target A1C level are often not met in spite of all the efforts that we have, and in spite of being very meticulously treating the patients with diabetes to the target. Unfortunately, 75% of the adult patients in Saudi Arabia with type 2 diabetes, they are not at hemoglobin A1C target. And of course, when we look into a very important trial, which is a CAPTURE study, this CAPTURE study, it was conducted in 2020. It's a large multinational study which demonstrate the cardiovascular risk in patients with type 2 diabetes, and it evaluates the prevalence of the atherosclerotic cardiovascular disease in type 2 diabetes. So, as you can see in the graph here, 1/3 of those people with diabetes, they have already established cardiovascular disease, and we have witnessed them in our clinical practice. There are almost 30% of our total populations of diabetes. 9 out of 10 people with diabetes type 2, they establish cardiovascular disease, and they have atherosclerotic cardiovascular disease. And only 2 out of 10 people with type 2 diabetes, they are getting glucose lowering treatment as a proven cardiovascular benefit. So this is exactly the summary of the study, which is a CAPTURE study. It highlighted that how common is atherosclerotic cardiovascular disease in type 2 diabetes, and it's also elegantly showing us the treatment gap in applying the modern cardioprotective therapy in the management of type 2 diabetes. So our objective, ladies and gentlemen, in this meeting is to illustrate the clinical inertia and the unmet need in type 2 diabetes. So the clinical inertia, as it was defined, is the failure of the physician to start or to up-titrate or to start an initiative for a patient that need that kind of intervention, and it's stated by the guidelines, and the patient is willing to have it, but the physicians or the doctor fail to do it. So this is the clinical inertia or the therapeutic inertia, which we are going to highlight it very much in this meeting. Again, we are going to discuss the interlink between the cardiovascular, kidney, and the metabolic disease. So it's a syndrome that it get connected together, and we are going to prove it by the evidence base, summarize the holistic approach of the current guidelines recommendations for type 2 diabetes. So we are living in the era of holistic approach, looking at the patient from different perspectives. The patient is not only body, the patient is body, mind, and soul. So applying the biopsychosocial model of care is the ultimate goal, and providing the patient with a basket of service, which is preventive, curative, and rehabilitative. And this is the main core of our practice as a primary care physician or even as a physician taking care of patients with diabetes. Also, we are going to, in this meeting, to emphasize the semaglutide role in the different CKM disease profile. So, ladies and gentlemen, I'm very proud to have a wonderful faculty today. Dr. Khafir Morales is Associate Clinical Professor of Medicine, Donald and Barbara Zucker School of Medicine at Hofstra Northwell. He's the Vice President at Advanced Internal Medicine Group in East Hills, New York. And we have also the well-known figure, Dr. Hussein Badawi, that I'm very proud to have him along with us here to give us the local expertise and the local flavor of the topic on CKM. He's a consultant with endocrinology and diabetes and metabolism, chairman of the metabolic unit in my clinic, Jeddah. So, ladies and gentlemen, our topics we are going to highlight to discuss today. It will be two topics. We will start with the first topic, which is going to be for Professor Khafir. So, the CKM syndrome and intimate interconnections requiring a holistic approach. So I would like just to remind you all, please put your questions in the Q&A box. So I'll be able, inshallah, to identify the appropriate questions and deliver it to the speakers. And hopefully we are going to have a wonderful and fruitful discussion at the end of this topic. Again, I would like to remind you that there will be a survey that I would like you to participate in at the end of the last presentation. So without any further ado, on your behalf, ladies and gentlemen, I would like to welcome Dr. Khafir Morales for accepting the invitations and being part of this wonderful session. So, Dr. Khafir, the floor is yours, and thank you for being with us here today.
Well, thanks so much for the gracious introduction, Dr. Amir. And it really is a privilege and an honor to be here and to share this virtual platform, both with you and with my dear friend there, Dr. Al-Badawi. So I am going to share my slides, and let's go here. And so sorry, one second, please. And let's go into show mode. And here we are. Okay, great. Yes. So yeah, so that's me. And today's presentation is really titled, as we've mentioned before, the intimate interconnection between the kidney, cardiac, metabolic syndrome, and how a holistic approach would be required in order to accomplish the incredible feats that we've been tasked to do. So for the most part, these are my disclosures for your review. And for the most part, today's presentation is really going to be focusing on how the cardiovascular kidney metabolic conditions are all kind of like interlinked. And as a consequence of there being tremendous interlink over the years, and we've known that one organ has an effect on the other, there's also been an evolution in the current guidelines that offer some guidance for managing our patients with diabetes and cardiorenal disease, namely the ADA guidelines. So we'll explore about how the ADA guidelines have evolved over these years, and also explore some of the rationale behind semaglutide's positioning in these very ADA guidelines. But first, I think it's important for all to remember that there is interconnectivity between the heart, the kidney, and metabolism. In fact, the heart and the kidney are probably the two most metabolically demanding organs in our body, consuming about a third or more of most of the sugar that's consumed or energy that we actually intake. And they tend to be codependent because the kidney is responsible for fluid and electrolyte balance, whereas the heart is responsible for disseminating the blood and circulation throughout the body in order to deliver the nutrients required for this metabolic activity. And the powerhouse is largely going to end up being the pancreas, with glucose uptake being driven largely by insulin production, but the liver also has a play in this as well. Now, we all know that patients with type 2 diabetes ultimately succumb to some kind of chronic kidney disease. In fact, about a quarter of our patients, or a third of our patients with diabetes, do suffer with chronic kidney disease. Now, the definition of chronic kidney disease is more than just a GFR of less than 60. But you also have to look at the urine albumin to creatinine ratio because a UACR of greater than 30 constitutes the fact that there has damage been occurring at the level of the kidney. And oftentimes that UACR will become abnormal before there's a decline in your glomerular filtration rate. And when we're looking at the primary causes of chronic kidney disease and progression to end-stage kidney disease, at least in the United States, it's largely driven by type 2 diabetes and hypertension, and I'm sure it's not that much different in the Kingdom of Saudi Arabia. But we do know that patients with type 2 diabetes, as was mentioned before, are at significant risk of developing adverse cardiovascular outcomes. In fact, about a third of patients with type 2 diabetes have concomitant cardiovascular disease. So it's more of a matter of just managing the glucose, but also reducing cardiometabolic risk in hopes of uh, trying to diffuse the possibilities of a cardiac event. And when we're looking at these events when they do occur, they wind up being not just physically taxing on the patient, but economically taxing on the healthcare system in general, because cardiovascular disease winds up being a major cause of comorbidities that arise in our patients with type 2 diabetes and healthcare expenditure. But let's take a look at the heart and the kidney both in combination, because when we look at this, our patients with chronic kidney disease are really broken down into different stages, stage 1, 2, 3, 4, 5, which is largely driven by glomerular filtration rate. But when we're looking at the relative percentage of patients in stage 1, 2, 3, 4, and 5, the lowest percentage is in those that have stage 4 and stage 5. And that's because they succumb to cardiovascular outcomes that are very poor. They often die of cardiovascular disease or end stage kidney disease, which is why it's very, very important to not just be GFR centric when it comes to making that diagnosis of chronic kidney disease, but also looking at the urine albumin to creatinine ratio. Okay, so now that we've established that there is a link between these different organs, the kidney and the heart and the liver, so this new concept of cardiovascular kidney metabolic syndrome has now been introduced. And not only is it introduced, but it's also staged. So at stage 0 is going to be your typical normal weighted individual who's quite healthy. And the focus for these individuals are largely going to be um, a healthy lifestyle, practicing a healthy diet, exercising, maintaining adequate hydration, and absolutely zero smoking. But then what happens is that once we start to become obese, these fat cells and this adiposity winds up being metabolically taxing and creates a milieu of events at the level of the body, including significant insulin resistance. This insulin resistance is what really drives the development of certain disorders, such as type 2 diabetes and even hypertension, which brings us into what we call the stage 2 of this cardiovascular kidney metabolic syndrome. And here, again, this adiposity leads to this milieu of abnormalities that could ultimately drive the development of type 2 diabetes. And that's all due to insulin resistance because of the adiposity. In addition, you also have dysregulation of several hormones within the body that can ultimately lead to fluid retention and exacerbation of hypertension. And as a result of the insulin resistance, oftentimes could lead to upregulation of lipoprotein lipases, oftentimes leading to dysregulation of lipid metabolism. And all of this will ultimately lead to the development of stage 3 disease. And in stage 3 disease, are really broken down into what we call subclinical atherosclerotic cardiovascular disease or subclinical heart failure. Remember, we see a lot of heart failure with preserved ejection fraction in our patients that may be obese with diabetes, probably even more so than heart failure with reduced ejection fraction. In fact, there are many patients who come into the office who might be coughing, and we think that they probably have either asthma or maybe some sort of upper respiratory infection, when indeed it may have been heart failure with preserved ejection fraction. But nonetheless, if they've not reached end stage targets, then what we really need to do is stratify our patients using risk calculators. Now, there's a myriad of risk calculators out there that we can certainly use, and they create a sense of urgency about when to start treating our patients. So when part of the chronic kidney disease, however, there is a consortium of nephrologists worldwide that get together called the KDIGO Group, or Kidney Disease Improving Global Outcomes. And what the KDIGO Group did was that they created this heat map. And this heat map actually plots the glomerular filtration rate to the urine albumin to creatinine ratio. And again, is a tool that helps to predict the progression of chronic kidney disease to end-stage kidney disease. So this year, they actually did a new reiteration of this KDIGO heat map, where instead of looking at the progression of chronic kidney disease, now we're looking at cardiovascular mortality with odds ratios. So again, it adds a little bit more color to the picture and the urgency of needing to treat our patients and hoping to avoid stage 4, which is end-stage disease. And this includes, as we know, having a heart attack or having a stroke, or even having a significant arrhythmia like atrial fibrillation. So I think it's really important to remember that early detection of this cardiovascular kidney metabolic syndrome could allow earlier intervention that hopes to halt the disease progression. So here on this side of the slide, for instance, here we're looking at how weight management can actually have significant impact on the development of some of these very risk factors that drive cardiovascular disease. For instance, if we're looking at lipid disorders, we could see that the heavier we are, going from overweight to obesity, leads to an increase in the odds ratio of developing significant dyslipidemia. Well, the same thing happens with blood pressure. In fact, we could see that these numbers are actually more linear than anything when we're looking at the effect on hypertension. But when we look at type 2 diabetes, wow, this suggests that there's a doubling of the effect, or maybe even a hyperbolic response that's driven largely by weight, which again emphasizes the need to really focus on treating our weight in hopes of preventing the development of type 2 diabetes. So what about taking a look at the kidney and the role that the kidney has in terms of developing these events? Well, the kidney has a significant impact, particularly when we're looking at stroke. Here we could see that at stage 1, stage 2, your hazard ratio is about 1.3. But when we get to stage 4 and stage 5, you could see that there's almost doubling of this rate. Again, emphasizing how later stage chronic kidney disease increases the risk of not just having a stroke, but also having a myocardial infarction, which is why you see so few patients in stage 4 and stage 5, because they are succumbing to mortality because of adverse cardiovascular outcomes. Well, let's take a look at type 2 diabetes and how this contributes towards events. Now, this was an actual elegant study. It looked at about 100,000 patients back in 1976. And what they did was they looked at that index point in 1976 of patients who have diabetes at baseline and those who do not have diabetes. And of course, the index ratio of 1.0 is for those who do not have diabetes. But if you had diabetes at baseline, take a look at the relative risk of MI or a stroke. It was significantly greater. In fact, it was 5-fold greater. So back in 1976, when they did have this baseline information obtained, they actually followed these people for about 20 years. And what they did was, by noting how they progressed, we could see that the risk of an event prior to the diabetes diagnosis actually increased. And that's with dysregulation of blood glucose, or the pre-diabetic state. And after you develop diabetes, or after it's formally diagnosed, you could see that it significantly worsens. So trying to control that blood glucose is going to be really important in hopes of trying to prevent MI or stroke in this population of patients. So over the years, we've had a myriad of new agents for our management of diabetes evolve. And as of 2008, the Food and Drug Administration mandated that all new glucose-lowering therapies be explored for cardiovascular benefit or harm, so to speak. So as a consequence, when we're looking at the evolution of the guidelines, particularly the ADA, we could see that in 2017, they recommended the introduction of either an SGLT2 or a GLP-1 receptor agonist for patients with type 2 diabetes with established cardiovascular disease. And this was on the premise of a cardiovascular outcome study that was successfully completed, demonstrating reduction of major adverse cardiovascular events. But since that time, we've had a myriad of clinical trials report out, And these guidelines, namely the ADA and the EASD, have evolved over the years, reflecting most of these changes. So, for instance, in 2019, they recommended using a GLP-1 or an SGLT2 independent of a baseline hemoglobin A1C to reduce cardiovascular events or CKD progression. In 2021, we started to recognize that heart failure is really, really important and does exist. And they actually had a pathway that was devised specifically for managing heart failure. And 1 year later, they looked at the SGLT2 inhibitors to reduce chronic kidney disease progression. But very important is the fact that using a GLP-1 receptor agonist with proven cardiovascular benefit could be implemented if the SGLT2 is not tolerated or contraindicated. Now, also in 2022, which is very important, was the fact that metformin was no longer recommended as first-line therapy for our management of patients with type 2 diabetes. Rather, you could use anything that you want, and using a medication that offers cardiovascular benefit seems to make most sense. So in 2023, we see that the SGLT2 inhibitors were recommended independent of the hemoglobin A1C to reduce CKD progression and cardiovascular events. And in 2024, which was last year, in patients with established atherosclerotic cardiovascular disease or CKD, again, GLP-1 or SGLT2 with proven cardiovascular benefit really should be part of the comprehensive cardiovascular risk reduction profile that really should be exercised. So how did the kidney team actually pay in? So here is the KDIGO heat map, or should I say the KDIGO recommendations. And in 2020, they recommended using an SGLT2 inhibitor. And for those who are unable to use an SGLT2 inhibitor, you could use a GLP-1 receptor agonist. In 2022, however, they also changed their recommendation to using a long-acting GLP-1 receptor agonist because all of these longer-acting GLP-1s demonstrated some form of reduction of major adverse cardiovascular event. And if we're looking at last year's or 2022's iteration of the American Diabetes Association and KDIGO, both concomitantly released a statement looking at SGLT2 inhibitors and GLP-1s with proven cardiovascular benefits for people not meeting the individualization of their glycemic target or unable to use any of these particular drugs. So what has happened over the years is that we've moved from a glucose-centric focus of attention to managing our patients to taking a holistic approach, not just to manage blood glucose, but to reduce cardiometabolic risk. So let's explore the American Diabetes Association standard of care, and let's see what it is that they have to offer here. Because here, when we're looking at this, it's a little bit cryptic. It looks a little bit confusing, but it's really broken down into several different items. First one is, and it's here at the top, is that healthy lifestyle behaviors really need to be exercised, and looking at diabetes self-management education and support programs, as well as social determinants of health. But when we look a little bit further, we can see that these guidelines are really broken down into people who just need glycemic control, those who need weight management, but more importantly, is focusing here on the cardiovascular renal aspect, because it's broken down into patients with established heart disease, those who may have high risk of heart disease, heart failure, chronic kidney disease, and down here at the bottom, now we start to look at the introduction of metabolic illness associated steatohepatitis or MASH, and how some of these agents could be beneficial when managing these patients. So semaglutide became approved as a once-weekly human analog of GLP-1. And it's a very interesting molecule because it is very similar, 94% homology to human GLP-1 with 2 amino acid substitutions, largely to prevent degradation by DPP-4. And we have a long fatty acid side chain attached to a spacer that allows the molecule to attach to albumin, allowing for the medication to be administered once weekly via injection. But history was made when they decided to combine this molecule with an absorption enhancer called SNAC, or sodium N-amino caprolate. And by combining semaglutide with SNAC allows the medication to be taken via mouth. So the semaglutide could be given via an injection once per week, but also could be taken as an oral tablet once daily. So what's kind of interesting is that when you're looking at the pharmacokinetics of the molecule, regardless of whether you're using 1 milligram subcutaneous or using the oral formulation of semaglutide at a dose of 14 milligrams once per day, they're nearly equivalent when it comes to measuring circulating levels of semaglutide. And whether it be injectable or whether it be oral, will offer significant benefit with respect to glucose lowering, weight management. And earlier this year, you did see that the SOUL trial did report with a favorable, statistically significant reduction in major adverse cardiovascular events in patients that were using the oral formulation of semaglutide. So either which way, either an injection or a tablet, you're going to get those cardiovascular benefits, including major adverse cardiovascular event reduction. So going back to this ADA recommendations, let's explore this in a little bit more detail. And let's take a look at atherosclerotic cardiovascular disease and high cardiovascular indications in some of these patients. And when we're looking at this, they do recommend using a GLP-1 with proven cardiovascular benefit or an SGLT2 inhibitor with proven cardiovascular benefit. But if you choose either or and your hemoglobin A1C is not at goal, then you should consider using one or the other. So it's really driving us down to consider concomitant use of a GLP-1 and an SGLT2 inhibitor, which is something that the European Society of Cardiology updated earlier this year for management of our patients with established cardiovascular disease or who have risk factors for cardiovascular disease. So where's the premise for this? When we're looking at GLP-1s and how they actually act on our cardiovascular system, for the most part, they do a lot of different things. By minimizing glycemic variability, reduces oxidative stress, and by doing so, we may be increasing local nitrous oxide, which improves circulation. As a consequence, by doing so, we also see reductions in ELAMs and ICAMs, and which can sometimes lead to improved blood flow and vasodilation. There's also some indication that there is less lipid accumulation, and because of its effect on PI1, which is a procoagulant messenger, there is reduction in PI1, which means that perhaps there might be decreased platelet aggregation. And all of this may translate into decreased inflammation at the level of the heart and decreased ischemic injury with improvement in left ventricular function for some of our patients. So where does this data come from, or where does this benefit or recommendation come from? Well, we're actually the very first trial that looked at reduction of major adverse cardiovascular events with semaglutide. And this was the SUSTAIN-6 study. So this trial was conducted in a high-risk population of patients with established cardiovascular disease and was an event-driven trial as well as a time-driven trial. And what we can see here in this study was that there was a statistical significant reduction in major adverse cardiovascular events in those patients that were treated with semaglutide on the order of 26%. So what I want to point your attention to is not so much the conclusion of the study, but I want to show you where these curves actually start to separate, which actually started to separate rather early, which means that this molecule really has something that's very special about it in terms of its ability to reduce major adverse cardiovascular events. Now, when we're looking at the driver of MACE events, it was kind of interesting to note that non-fatal stroke was reduced by about 39% in these patients that were treated with semaglutide and was indeed the driver of the reduction of MACE events. So much so that the Stroke Society does specifically call out semaglutide as an agent to use in our patients that have suffered a stroke in order to prevent a subsequent stroke. And we do know that within 3 years of having a stroke, a patient with type 2 diabetes will experience likely another stroke. So what about peripheral arteriolar disease? Because we talked about the heart, and when we're talking about cardiovascular, cardiac is the heart, but vascular actually implies also the carotids and cerebral circulation, but also peripheral vascular disease as well. I think it's important to remember that a lot of patients are underdiagnosed with peripheral arteriolar disease, and it's largely because everybody drives. Nobody's really taking long walks anymore. So here we looked to see whether or not semaglutide had a significant benefit in patients who may have arteriolar disease or peripheral arteriolar disease. So you needed to have a diagnosis of type 2 diabetes 180 degrees prior to screening, and your hemoglobin A1C was actually not that bad at entry in this particular study. It was probably around 7.1%, but and 72% of these patients wound up being smokers and have had diabetes for about 12 years. So these patients had to have some intermittent claudication and had to have at least 200 meters of pain-free walking with a maximum walking distance of around less than 600 meters on a constant load or flat treadmill test. And on examination, had to have an ABI or toe brachial index of 0.9 or 0.7 or less, respectively. So these patients were really randomized to starting semaglutide, titrating up to a dose of 1 milligram per week on top of standard of care, or placebo on top of standard of care. And the primary endpoint was really looking at the change from baseline in maximum walking distance on a constant load treadmill test at about 52 weeks. This is what we saw. So the treadmill load wound up being an inclination of about 12 degrees or so, and they were walking at about maybe 3 meters per second. And when we take a look at what the outcomes was, there was a 13% improvement in mean walking distance compared to placebo on top of standard of care. This was statistically significant with a mean improvement of walking approximately 40 meters more. So, and again, this was at 3.2 kilometers per hour with an inclination of about 12%. Doesn't sound like much, but in somebody who has peripheral arteriolar disease, it could make a huge difference. And once again, if you're looking at this timeline, we could take a look that there was significant separation at the conclusion. But when we're looking at these people over time, you could see that there was a nice clear separation of these curves. So what does this really mean? So if you have an improvement in your mean walking distance by about 13% relative to placebo, then that means that you'll probably have a 40-meter increase, which is about being able to walk half of a football field in a fairly steep incline. So that's actually quite good, improves the quality of life. But let's explore these data in a little bit more detail, because now we're looking at all-cause mortality or major adverse limb event. Now, in these patients that did have peripheral arteriolar disease, for the most part, they were allowed to be rescued, and the rescue medications included cilostazol or pentoxiflin. And we could see that 54% of these people were less likely to experience some sort of mortality or major adverse limb event compared to those that were rescued with placebo. So when it comes to the continuum of cardiovascular disease, I think it's really important to remember that this all starts with precursors. And these precursors include dyslipidemia, hypertension, diabetes, and obesity. And this leads to a continuum or a timeline of events that ultimately will lead to the myocardial infarction or heart failure or recurrent stroke. However, if we start treating earlier with semaglutide, regardless of whether it's oral or whether it's an injectable, we can actually derail this whole process simply by helping to control some of these very risk factors that might be the driver. So how does semaglutide compare in a real-world setting? So this is data from the Evolution study, which was an observational study that was conducted in your kingdom of Saudi Arabia. So here we looked at the clinical effectiveness of semaglutide in patients with uncontrolled diabetes. Now, what was kind of interesting is that the average hemoglobin A1C at entry for these patients wound up being around 10% or so. And about 80% of the patients were using the injectable form of semaglutide relative to the oral. So we looked at the timeline, which is time zero, and patients needed to be on a stable dose of glucose-lowering agents at least 3 months prior to being switched to semaglutide. So once they got switched to semaglutide, we followed their outcomes over 6 months. And what we did see that there was significant improvement that was noted with a reduction in hemoglobin A1C of about 3.1%. But not only did we have the improvement in the hemoglobin A1C, but those very parameters that may help to drive the atherosclerotic process and increase your risk of major adverse cardiovascular events were actually reduced as well. We saw a reduction in systolic blood pressure of about 8.1 millimeters in these patients. We had an LDL reduction of about maybe 16 milligrams per cent and a triglyceride reduction of about 33 milligrams per deciliter. What's also very interesting is that the average weight loss that was demonstrated at the conclusion of the study wound up being about 19% in this population of patients in your Kingdom of Saudi Arabia. So let's explore this ADA recommendation once again. And now that we talked about the cardiovascular aspect, let's talk about heart failure, because we see this quite a bit. And heart failure, for the most part, could be taken care of by either an SGLT2 inhibitor with proven cardiovascular benefit. But what about the GLP-1 receptor agonist? So the new recommendation update, which gained a level A recommendation, is that in patients with type 2 diabetes with symptomatic heart failure, with preserved ejection fraction and obesity, a GLP-1 with demonstrable benefits is really recommended. And this is irrespective of the hemoglobin A1C. So here we have some data from the FLOW trial. So the FLOW trial was a dedicated study looking at the kidney and the effect of semaglutide on the kidney, but we really didn't just look at the kidney. We looked at heart failure, we looked at hospitalizations for heart failure, or even cardiovascular death. And here on the left-hand side of the slide, here we're looking at time to first of the composite heart failure outcome, which included the 3 points of hospitalization, an urgent heart failure visit, or cardiovascular death. And there was a statistical significant reduction in favor of semaglutide by about 27%. Now, death is never fun, obviously, but if we were to remove death from the equation, would we see the very same benefit? And yes, indeed we did, because here on the right-hand side of the slide, if we're looking at heart failure requiring hospitalization or an urgent heart failure visit, again, a 27% reduction, which satisfied statistical significance, was also noted. And I do need to call out that the heart failure benefit did occur quite early, as we can see in these Kaplan-Meier curves. So what about in patients without diabetes? So this was a trial that was actually done looking at a higher dose of semaglutide, particularly for obesity. And this is the 2.4 milligram dose of semaglutide. And this was pooled events. And when we're looking at pooled studies across all of these different trials, here we could see that there was a significant reduction in heart failure events, time to the first event or worsening heart failure in favor of the semaglutide. Not only did it happen at the conclusion of this study, satisfying statistical significance, but again, it happened quite early. So let's take a look at this 41% reduction in this overall analysis. And here we could see in this forest plot that it was statistically significant for all the doses that were studied of semaglutide. And I say all the doses because STEP both explored 2.4 milligrams, SELECT explored 2.4, and FLOW only 1 milligram. And we could see that all of these points all fall to the left of the line of unity, with statistical significance noted particularly in those who had obesity in the absence of diabetes, but contributed to a statistical significant reduction across the board of 41%. So now moving on in terms of our recommendations from the American Diabetes Association, let's talk about the kidneys. Because as I mentioned before, the kidneys are associated with adverse cardiovascular events. And here, the definition was really a GFR of less than 60 or a urine albumin to creatinine ratio of greater than 30. And we could see that the SGLT2 inhibitors were recommended, or a GLP-1 with proven chronic kidney disease benefit if you can't take an SGLT2 inhibitor. So let's explore the new recommendations, which claims that patients who have chronic kidney disease related to diabetes, you could use either an SGLT2 inhibitor or a GLP-1, but if your GFR is less than 30, a GLP-1 receptor agonist really would be preferred. So here's the FLOW study, which was a dedicated trial looking at two things, and that was a greater than 50% reduction in glomerular filtration rate in our patients with type 2 diabetes, or death related to chronic kidney disease or cardiovascular reasons. And what we did see here was that there was a 24% risk reduction of first composite kidney event in patients with type 2 diabetes. And that included that 50% reduction in GFR, or kidney-related death. And if we're looking here at this forest plot, we could see that the driver was protecting the kidney, preventing the onset of a persistent greater than 50% reduction in glomerular filtration rate was the real driver behind this 24% relative risk reduction and that was noted, that was statistical significance. But what I do, and also cardiovascular death was also a major driver. So these were the two drivers behind why we saw that statistical significant result. But what was really important here was that the study was actually stopped after 36 months. And the reason why is because the statistical significant reduction in these events were actually achieved by month number 36. And it actually is unethical to keep the placebo group on such beneficial therapy. So 24% reduction, largely driven by both a reduction in the progression of chronic kidney disease and also reduction in cardiovascular death. Now, I've been talking about glomerular filtration rate, but what about the urine albumin to creatinine ratio? Remember, UACR becomes abnormal before there's a decrease in glomerular filtration rate. And if you're at high risk, then the ADA recommends a 30% reduction in your UACR. And when we're looking at semaglutide in general, not only did we break that 30% reduction, but we actually brought it down to 40%. Not only did we have a 40% reduction in UACR, but it was actually sustainable over the whole course of observation in this clinical trial. So how does the Saudi Food and Drug Authority view all of this information? Well, they recommend once weekly semaglutide for management of type 2 diabetes as an adjunct to diet and exercise, but it also has the indication in your country to reduce the risk of major adverse cardiovascular events, as well as to reduce the risk of sustained decline in glomerular filtration rate, kidney failure, including initiation of chronic renal replacement therapy, or death from kidney failure or cardiovascular disease. So going back to the KDIGO, I'm going back to the ADA recommendations. Well, let's explore the glycemic control. And I'm not going to belabor this too much because this is a pretty busy slide, but it actually was the phase 3 development program for the injectable version of semaglutide. And you could see here that compared to monotherapy, compared to orals, or even compared to other GLP-1 receptor agonists, some of these dosed once weekly and once daily, you could see that the efficacy in the dark blue line was favored significantly for semaglutide. So the glucose lowering effect is actually quite there. And when we're looking at the weight management issue, well, we did talk about weight and we know the importance of weight, but again, looking at the phase 3 data, we could see that across all of these different trials, whether it be compared to monotherapy, orals, or even other weekly GLP-1s or daily GLP-1s, the bars tell the story that the weight benefit that you see with semaglutide was superior from a statistical standpoint compared to all other agents. Also, what I want to call out is this particular trial here, because this was patients that were already on basal insulin who needed intensification of therapy. And if they did need intensification of therapy, they actually did better by adding semaglutide rather than adding full physiologic replacement with 4 injections per day. But not only that, but if you were to intensify using semaglutide instead of insulin, there was also a weight benefit that was favored by semaglutide. Now, semaglutide is also approved for the management of obesity through the trade name Wegovy at a dose of 2.4 milligrams once weekly. And it has had a very extensive development program. Here you could see all of the completed studies with semaglutide as step 1 for weight management. We looked at weight management in patients with type 2 diabetes and so on and so forth. There was an Asian trial in many different countries. There was head-to-head against liraglutide and so on and so forth. And there are some ongoing studies that have been actually started and completing. And that is looking at the STEP study in young or adolescents, children, looking at higher doses of semaglutide as high as from 2.4 up to 7.2 milligrams weekly, both in patients without diabetes and those with diabetes. There's an employer trail, and there's also some studies that are being conducted in China as well as Taiwan. And What are planned is some studies looking at the effect of semaglutide 2.4 in Japan, as well as for chronic weight maintenance in our adolescents. Speaking about adolescents, here what we could see here is that there was one trial called the Step 4 study. And in the Step 4 study, yes?
2 minutes, please.
Yep. Okay, very good. So here we looked at the Step 4 study, which was in patients that were started with semaglutide, and they were actually treated for about 20 weeks before being randomized to either placebo or to continue with semaglutide. Now, the early responders were people who lost about 5% of their weight right from the very, very beginning. And for those early responders, what we did see that for those who continued with semaglutide, you could see that the mean weight change was about maybe 20% or so. So that was actually quite favorable. Now let's take a look at another trial looking at Step 5. Now in the Step 5 study, here we had patients that were only on semaglutide or semaglutide on top of other therapies relative to placebo. And here we could take a look at the weight loss that was achieved, and we could see there was a rapid reduction in that body weight in those patients that were treated with semaglutide over time. And we could see that it was actually quite sustainable all the way to week 104. Now, when we look at those patients that were on treatment relative to placebo, I mean, placebo didn't do so bad in terms of being able to achieve a 5% weight loss. But when we look at the total percentage of patients, we could see that 83% of these patients were successfully able to achieve 5% of weight loss. But when we look at how many lost 20%, almost 40% of these patients were able to achieve at least 40% of weight loss in this clinical trial. Now, we talked about the adolescent population, and that's a little bit difficult to define only because of the fact that in the adolescent population, they grow, but there are charts, and we can see that even in adolescence, which is a big problem, not just in your region, but worldwide, we were able to successfully achieve about 18% weight loss in these adolescents that were treated with semaglutide at 2.4. Now, semaglutide was also treated for cardiovascular disease in patients without diabetes. And this was the SELECT study. And what we did see here is relative to placebo, there was a reduction of major adverse cardiovascular events that was on the order of about 20%, with a 19% reduction of all-cause mortality. Now, what's also really interesting here is, yeah, I'm talking about weight, and weight, but take a look at where the curves actually start to separate. They actually start to separate before any meaningful weight loss was actually noted in these particular patients that were treated without diabetes, which means that the molecule, the cardiovascular benefit that we're seeing, is not weight dependent, but rather something inherent about the molecule. The European Society of Cardiology also calls out specifically for chronic coronary syndromes the use of a medication, and specifically calls out semaglutide. So when we look at all of these cardiovascular outcomes study, yes, we do know that the SURPASS study was recently reported, and it did show statistical superiority compared to placebo, non-inferiority compared to dulaglutide, but the details are not there. However, when we're looking at all of these other clinical trials that have been conducted, I'm happy to say here that semaglutide completed 4 different studies. The 4th is actually the SOUL study with the oral version that did demonstrate statistical significance in favor of semaglutide in reducing cardiovascular outcomes. So liver, we know about the fibrosis issue. We touched about MASH before, but when we're looking at patients that were treated with 2.4 milligrams of semaglutide, we saw statistical significant improvement of their liver function and also no worsening of liver fibrosis. And in fact, there was also improvement in liver fibrosis that was actually noted in these patients. So the Saudi Food and Drug Administration did give a label for semaglutide 2.4 as an indication as an adjunct to physical activity, particularly in adults with a BMI of greater than 30 or greater than 27 with at least one cardiovascular risk factor, but also recognizes that it can be used in adolescents over the age of 12 to help to control their weight. So just to summarize real quick, we talked about how weight loss really actually is beneficial, not just in the teens, but in adults as well. We did see reductions in cardiovascular events, not just in SUSTAIN 6, but in many other different trials, including the SOUL study. it actually did reduction in the progression of chronic kidney disease, but reduced all-cause mortality by about 20% in the FLOW trial, with improvement in heart failure and kidney outcomes, as well as the liver benefits that I just mentioned before. So, and can't forget the peripheral arteriolar disease, because there was improvement in those patients with established peripheral arteriolar disease on the order of 13%, allowing an improvement of about 40 meters of walking more. So that's really it. Thank you so much. And I'm so sorry I took so much of your time.
Thank you so much, Professor Javier Morales, for the wonderful presentation. You have highlighted the cardiovascular kidney metabolic syndrome and the role of the semaglutide in managing patients with diabetes along with this syndrome. So now, for the sake of time, I would like to introduce our next speaker, Dr. Hussein Badawi. He's a consultant in endocrinology and diabetes and metabolism, chairman of the metabolic unit at My Clinic Center, director of diabetes management program of My Clinic Center. So now we are going to move towards something which is very unique, which is the real world evidence and practice. So Dr. Hussein is going to explore the real world evidence for the holistic diabetes management and the clinical case-based discussion. So thank you so much, Dr. Hussein, for being with us here today and accepting our invitation. Looking forward to hear a wonderful presentation that touched the reality of our clinical practice here in the Kingdom of Saudi Arabia. Thank you so much. The floor is yours.
Thank you very much, Dr. Amir. I extend my thanks to the organizing committee from the society and thank Dr. Morales for this comprehensive talk that actually paved the way for what I'm about to present, because my duty is to try to compile all of this data and knowledge into practical means of how we can start using this in our clinic to help our patients live longer, happier, and healthier lives starting from tomorrow. So I will be sharing 2 cases. Here are my disclosures. I'm friends with anyone who helps me treat diabetes. And this is our first case, Mr. G. So he's a 60-year-old gentleman who's been diagnosed with type 2 diabetes for 15 years. Unfortunately, he sustained a stroke 10 years prior to him coming to see us. And during our encounter, he mentioned that he started to feel some spasms and achy pains while he walks in his calves. And that is sort of what's known as intermittent claudication. Now, reviewing some of his medications, these are his medications that he came to us on. He's on linagliptin, a DPP-4 inhibitor. He's on a combination pill of SGLT2 inhibitor with metformin. He's on insulin degludec, as well as aspart insulin, which was recently started because of uncontrolled diabetes. He is on a statin as well as an ARB and clopidogrel because of that history of a stroke. Looking into some of his blood work, we can see that A1C was 7.7. Of course, his goal should be below 7. GFR is at 90, and urine albumin creatinine ratio was normal. His BMI is at 32, making him at class 1 obesity. He had an ABI, or an ankle brachial index, which was triggered by this intermittent claudication. We said, let's just check the screen for peripheral artery disease. And long and behold, you can see that 0.9 is actually at the cutoff of being potentially having some sort of peripheral artery disease. Now, when we had the discussion with him, we asked him, what are your primary goals? So one goal that he had was to try to lose weight. He felt that it's very, very difficult and almost impossible to lose weight, especially with the amount of insulin that he takes, as well as the limitation of exercise and walking. He wants to at least see that 7%, which he hasn't seen in a very long time, and wanted to minimize the risk of having another stroke or another vascular complication. So from what we've learned from Dr. Morales in the past talk, I think we have a tool that can actually address several issues and several, let's say, targets, such as the glycemic control, the weight, as well as benefit for the kidneys and the peripheral artery disease. So let me just share with you how he looks like. So this is his vital signs. His weight is at 93. As I showed you, his BMI is around 30. and his blood pressure is just above 140. Our goal should be around 135. Now, palpating his dorsalis pedis, we felt that there were faint pulses, especially on the left. And this is what you do when you take them for more accurate testing using ultrasonography and using Doppler. And this is in his right dorsal pedis, where you can see the systolic and then the diastolic flow coming down. So we actually had good amplitude of this of his pulses. But when you come to compare the left side, here you can see that the faint pulses are truly faint because we barely have some flow. And especially when it comes to diastole, you can see that there's almost as if there's absence of that circulation. So this is something that we should pay more and more attention to, especially with patients who have had long-lasting disease. Now, as we heard, semaglutide would be the optimal choice, and that's what we offered him. So we stopped the DPP-4 linagliptin, gave him semaglutide, started at 0.25 weekly, and then escalated monthly to 0.5, then 1 milligram, which he continued on. And you can see that he was very happy because within 4 months, you can see here, this was in June, his weight at baseline was 93, coming down nicely all the way to 83 kilos when we came to see him after 3 months. Now, not only that, but you can take a look that his blood pressure improved, his BMI was very close to normal, and his weight at the end of a whole year of therapy was around 8, so almost 13 kilos in a patient with type 2 diabetes, and not only that, but also insulin requiring or insulin using. Now, he had been able to titrate down his basal insulin and almost get off all of his prandial insulin. And you can see here's the progression of the improvement of the glycemic control when we added the semaglutide. So within the first 3 months, we were able to bring down the A1C all the way down to 6.3. Now, we always help our patients down titrate insulin, avoid hypoglycemia. And then he was able to maintain very good control all the way down to 5.9 without hypoglycemia and minimizing the amount of insulin as well as weight. So he was a very happy person afterwards. Moving on to our second case, you can see that this is a younger patient who is Mr. Fahad. He's a 38-year-old engineer who had type 2 diabetes for 5 years, and he presented with uncontrolled type 2 diabetes. He was very scared because he thought that having an EGFR above 60 or creatinine that is normal means that his kidneys are protected, but was surprised that having proteinuria, which is an elevated UACR, means that he is probably in chronic kidney disease. These are his medications at presentation. So he tried to avoid insulin by any means. And that's why you can see that he's on the maximum dose of almost all of the oral anti-diabetic drugs, such as empagliflozin, metformin. He was placed on dulaglutide. And despite that, his A1C was still uncontrolled. His BMI is in class 3 obesity. And he really was scared about this issue with kidneys. So one of his major, let's say, goals of therapy was to try to control and protect the kidneys, in addition to controlling his weight and glycemic control. So our simple substitution was switch the dulaglutide to semaglutide, which we believe is a little stronger, but because we know that there may be equivalent doses between 1.5 and 0.5 of semaglutide, yet we always start with the way that it is prescribed in the packet insert, where you start with the low dose of 0.25 in the first month on a weekly basis. Then we intensify to 0.5 and then 1 milligram in the third month. And you can see here, he beautifully came down for almost 8 to 7.4. Continuous therapy led to improvement all the way down to 6.4. So a number that he had been dreaming of getting to for so many years. And taking a look at whether the flow trial taught us that there was any difference in the response in people who received semaglutide with high BMI or even a low normal BMI, all of them had kidney protection. So we were able to reassure Fahad here that there will be protection when we include semaglutide as part of his regimen. And this is his weight. So his weight also came down from 117 all the way down to 110. And then every few months, you can see that there is some fluctuation, but within a very tight range. So on average, we'll say 6 to 7 kilograms that he was able to lose. This is what was reflected on his proteinuria. So starting from here, where he started to see escalation of the levels, he peaked at 127, which was very scary for him. But as soon as semaglutide came along, he was able to come down all the way down to normal albuminuria. And then, with time was in his very good control of A1C and better weight management, we were able to keep him away from the 100 milligram per gram of albuminuria and maintain a relatively good number. The last time we saw him, which was just 3 months ago, he was able to, for the first time in a while, get to normal albuminuria. You can see that his blood pressure was improved as well. His BMI still at class 2, but relatively speaking, as an overall, let's say, holistic approach to the cardiorenal metabolic system, you can see that the cardio indicator of blood pressure was improved. The risk factor for cardiovascular disease, albuminuria, improved. His glycemic control improved, as well as his weight. So this is also the end of a second successful story. So I'll stop here, and we'll move on to our moderator for the discussion.
Thank you so much, Dr. Hussein, for these wonderful presentations. You have highlighted the real-world clinical evidence and the clinical practice in these two case scenarios. So now we would like to start our session by the Q&A session, and we have got a couple of questions. I think the audience, they were very much interested, so they gave us a good number of questions. The first question is for Dr. Khafir. In what way does the CKM syndrome represent a continuum of disease rather than isolated clinical events? So it's a continuum. It's rather than a single event. So how this kind of representation?
Well, it's a great question. I think what we need to remember here is that the fact that a lot of these organs are all interdependent on one another. The atherosclerotic process is usually driven by dysfunction of one or more of these organs. So in the particular situation where you have obesity and hypertension and dyslipidemia, that all leads to this whole atherosclerotic process that not only affects the heart, but it also affects the kidney as well. So, and we always have this discussion about when would an SGLT2 or a GLP-1 be better in terms of treating patients along this continuum. And if you look at this timeline and you look at all the published data that has been completed, it seems that the SGLT2 inhibitors really have significant shine when it comes to managing heart failure, and cardiovascular mortality for many different reasons. But when you're looking at how the GLP-1s work, they can actually derail the whole atherosclerotic process that leads to the event to begin with that may have precipitated the heart failure. So I hope that kind of explains the question.
Yes, thank you so much. Dr. Hussein, a question for you. How might the real-world data that you have described in your clinical scenarios contribute to updating clinical guidelines to better reflect the complexity of managing of diabetes as a multi-system disease rather than a single entity that we're talking? And this is actually the trend that we're always handling diabetes, hypertension, dyslipidemia, obesity as single entities rather than a complexity of multi-system presentation.
I agree. I think it's there's this discrepancy between what we learn when it comes to disease pathophysiology and imagine that the patient's only going to come with that single disease. But in reality, most patients with type 2 diabetes are going to come with this package of metabolic diseases or the cardiometabolic syndrome or cardiorenal liver metabolic syndrome. So understanding the, let's say, or visualizing the patient in this holistic approach will definitely make you a better clinician as you explain each element to the patient as opposed to just being a diabetologist where I restrict myself to just talking about diabetes and becoming glycemic centric. So I think this is the new reality and how we should all act with our patients.
Okay, thank you so
Not
much.
only that, but if I can add, I think this is also really important because so many different organ systems are involved. And being that this is a family medicine conference, I think this actually opens the opportunity to even greater collaboration with our specialist colleagues and communicating what our recommendations may be to help treat the patient. Remember, at the end of the day, we're the ones that are in charge because the patients are seeing us, the primary care clinicians, more so than their specialists. So we're identifying sooner, we're implementing therapies sooner. And as a consequence, we actually are the ones that should be communicating with our colleagues.
Yeah. I think there is another question which is quite interesting. It comes as an extension to the previous one. It's for you, Dr. Khafir. How can early detections of CKM syndrome change the trajectory of long-term outcome compared to treating condition in silos? And this is a major concern by the primary care physicians. So we would like to push them a little bit more to detect those patients with cardiovascular kidney metabolic syndromes and to identify those population at risk of having this kind of presentation rather than treating the single. So what's your comment on this?
Well,
the
I
role
think
of early detections.
Yeah, of course. I think it's important to remember that many of these agents not only will tackle one process, but may tackle more than one. So for instance, when we were just talking about before how, dysglycemia ultimately leads to kidney dysfunction or heart dysfunction, then selecting an agent that would actually have benefit on a kidney standpoint and heart standpoint, you may actually get 3 bounces out of that stone if you're skimming it across the lake rather than just one. So for instance, medication selection winds up being of critical importance. So here you have somebody who has type 2 diabetes and your options are, well, you could put them on a sulfonylurea. Well, you're going to lower their glucose. You might make them hypoglycemic, but there's no renal benefit or heart benefit. You could put them on a DPP-4 inhibitor. And again, if you're letting economics drive your decision choice, then the long-term savings might be lost. So some of these newer agents, and they are newer, and I get it, they tend to be more expensive, do offer significantly greater benefit on other target organs that they will eventually keep the patient out of the hospital and reduce the risk of hospitalization and also mortality. Now, there was a beautiful meta-analysis that was published last year looking at incremental, and this is purely meta-analysis and a calculation. They looked at sequential introduction of all of these cardioprotective agents. And these included GLP-1s, SGLT2s, RAS inhibition, and also the non-steroidal mineralocorticoid receptor antagonist, finerenone. And it showed that from a mathematical standpoint, the benefits would be great. Does that mean that the patient will never end up in the hospital with a heart attack or heart failure? No, but I think that if you're using all of these agents that offer benefit, you'll reduce the residual risk that much further and make the likelihood of an event being significantly less.
Yeah, well said, Dr. Khafir. And being a family physician, I would like to say that now we are moving towards a different era of engagement with our patient with diabetes. We are not there only to tackle the A1C and to bring the A1C to the target, but also to provide the patient with diabetes with a cardio-kidney metabolic benefits by using these cardioprotective medications and medication that goes beyond the glycemic control and preserve the functionality of different organs that constitute the cardio-kidney metabolic syndrome. And I remember here, the American Academy of Family Physicians, they said a very nice statement. They said, if a patient comes with acute coronary syndrome and he went to the cath lab or for a CABG, he will be counted as a failure of the primary care physician who did not do his job well. As a primary care physicians, we are here to protect our patients, to be the gatekeeper, to identify those people at risk and to manage those people at risk with the early protections. And nowadays, we are capable of doing this with our knowledge, with the good guidelines that we have, and with the smart molecules that we have as well. This is a real privilege for us as a primary care physician. Dr. Khafir, there is a very nice, interesting question for you again. What is the evidence on semaglutide role in modulating inflammation and endothelial functions independent of glucose control? I think you have mentioned it in your presentation.
Yeah, no, that's great. That's great. Yes. So it's kind of interesting because when you look at markers of endothelial function, one of the ones that really have been credited as a good corollary is HSCRP. And if we're looking at HSCRP levels, they tend to go down when you're using the molecule semaglutide, and even more so when you're comparing it to other agents that offer cardiovascular benefit. For instance, there was a head-to-head study in the SUSTAIN-2 trial that looked at empagliflozin, actually, and the HSCRP actually did go down that much more with semaglutide than it did with the SGLT2 inhibitor. Furthermore, is that during the phase 1 trials of the molecule, they did measure ELAM expression and ICAM expressions, and it did reduce. So there is the suggestion that perhaps there is an anti-inflammatory effect that's offered by semaglutide, and perhaps that could be part of the driver in terms of why we're seeing such fewer events.
Excellent. Another question is, what are the latest insight on combining semaglutide with SGLT2 inhibitors? Are the benefits simply additive, or do we see a synergistic metabolic and cardiorenal effect?
Wow, that's a great question. And I am going to likely say that it's going to end up being a synergistic effect.
Okay.
And part of the reason why is because if you're looking at the GLP-1s decrease inflammation, and they may offer a greater weight benefit than the SGLT2s do, and we've seen that. But at the same token, when we're looking at the SGLT2 inhibitors, for the most part, they're uricosuric. They're sympatholytic to some degree. They raise beta hydroxybutyrate. They raise intracellular magnesium levels. And these are probably the drivers why we're seeing such benefit with the SGLT2s. So when we're looking at both of these in combination, there is benefit that one could see. Now, where's the evidence? The evidence is only one trial so far. That trial was the Amplitude-O study that looked at, and it wasn't a human-based GLP-1, it was an Exendin-4-based molecule, and they looked at patients that were using it in combination with an SGLT2 or without, and there was a greater reduction in MACE events in those that were using it in combination with. So there's a suggestion there that that there is a synergistic effect. Now, how do the guidelines view this? So it's kind of interesting because, as I mentioned during the course of my talk, is that the European Society of Cardiology, when it comes to managing patients with established cardiovascular disease, they used to say either a GLP-1 or an SGLT2 inhibitor with cardiovascular benefit, but new is that they say that you use a GLP-1 and an SGLT2 inhibitor, both in combination. So they're recommending additive therapy.
Yeah, well said, Dr. Khafir. In the era where we are witnessing a lot of added benefits in using the GLP-1, what is the fate of the DPP-4? Is it going to be vanishing gradually, like what we are witnessing now with the sulfonylurea? What is the future of the DPP-4 in the era of the GLP-1?
Well, the DPP-4 inhibitor does work to some degree by restoring physiologically secreted GLP-1 at GLP-1 at physiologic levels. I think that the DPP-4 inhibitors probably have more of their effect by suppressing glucagon release. I think that's mainly the driver, but they tend to be more weight neutral. Their A1C reduction tends to be somewhat limited, and I think that they will go away. They kind of came in at the perfect storm, and that's when there was some uncertainties about the safeties of thiazolidinediones, which have now been mitigated, and TZDs are actually quite safe to use and very beneficial in terms of insulin secretion, and they also offer MACE reduction. But if we're all using GLP-1 receptor agonists, and they're going to be the mainstay of therapy, there'll be no reason to use a DPP-4 inhibitor because we're already giving super physiologic levels of GLP-1, and the DPP-4 only raises GLP-1s to just physiologic levels. So I think that the DPP-4s will actually go away. In addition, what's kind of interesting about the DPP-4 is that the enzyme DPP-4 is also responsible for breaking down PYY. So, or should I say, it leads to greater PYY breakdown, which is probably one of the drivers or one of the reasons why we're not seeing as much weight benefit with these agents.
Okay.
Another talk for another day.
Yeah, that's great. Okay, I think we are coming to the end, but before I close, Professor Hafir, I would like you just to say one single statement as a conclusion and a take-home message for the primary care physician in managing the syndrome of the CKM using the semaglutide. What would you do? What would you like to say?
Sure. First, I'll start by saying that the ball is in your court as the primary care provider. You're seeing all the patients. They're all coming to you for your guidance and for your management abilities. I think it's important to remember that all of these organ systems are all interconnected. The molecule semaglutide, whether it be injectable or oral, does offer benefit, not just in terms of glycemic control, but also in terms of controlling this cardio kidney metabolic milieu as we know it. And if we're looking for additional weight benefit, then that very same molecule is available at higher doses in Wegovy that offer very similar benefits in terms of the A1C reduction abilities and also demonstrated a reduction in major adverse cardiovascular events.
Excellent. From my side, I would like to say to my colleagues as in primary care, I would like to say thanks to GLP-1 that brought different specialty and multidisciplinary specialty sitting together on the same table. So along with us as the family physicians of primary care, we have the endocrinologists, nephrologists, cardiologists sitting together, working together for the best interest of our patients with diabetes. So to work and to protect our patients with, to add the kidney metabolic benefits on top of the treatment of diabetes using this semaglutide that's proven to be efficient, safe, and tolerable as well. With this, ladies and gentlemen, I would like to thank our guest speakers, Dr. Hafir Morales and Dr. Hussein Badawi for their wonderful contributions. And I would like also to thank the Saudi Society for Family and Community Medicine. And special thanks goes to special thanks goes to ملتقى الخبرات لتنظيم المعارض والمؤتمرات and Novo Nordics for giving us this wonderful opportunity to be here together. And I just would like to remind you, ladies and gentlemen, take a moment to complete the evaluation form for your feedback. Your feedback is valuable to us in order to improve our presentations and the way we deliver these messages to you to make it more compatible with whatever you need. With this, I would like to thank you all for being with us here tonight. And please carry the message that we have delivered today to you. Be confident enough to manage your patient with diabetes beyond the traditional management of treating the disease in solo, to think about the disease in terms of CKM syndrome and pay attention that we can deliver the benefits, we can protect patients from cardiovascular mortalities and improve the quality of life. With this, ladies and gentlemen, I would like to thank you very much. Looking forward to see you again in other scientific events. With this, have a good night and see you later. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much, Prof.
Okay, good to see you all.
Thank you. Looking forward to see you back again here in Jeddah soon.
Looking forward to it.
Or in Vienna. All right.
Thank you, and have a great evening, you guys.
Yeah, thank you so much. Wish you
Yes.
the same. شكرا دكتور عبد الحفيظ. Everything. Thank you, everyone.
شكرا دكتور أشرف. شكرا